Really nice to see everyone. Thank you for joining. I'm Rose Maylin. I'm a practice nurse, but in this role, I'm actually a parish nurse as well. And I'll talk a little bit about parish nursing at the end. But my background in nursing is I've specialised in respiratory long-term conditions as well as diabetes. And then within parish nursing, deal with the whole person in lots of different aspects. So I thought today I would just go through asthma and what it is and so on. Now, if you have questions, we could perhaps address them at the end. But if you've got a burning question in the meantime, then maybe let Liv know by putting your hand up and, if there's something that you want to ask. So thank you for joining us. Next slide, please, Liv. I feel like Chris Whitty. So what is asthma? So it's a variable long-term inflammatory condition. So if you can see the picture here with the normal airways and normal lung with the muscles relaxed, so you've got the normal lining of the airways with muscle around it and a normal amount of mucus in it. And then on the other side, you've got the asthmatic lung, where you've got lots of inflammation that causes the airway to be completely swollen. I often say to people, it's sort of soggy, a bit like very weepy eczema, if you see that on people, where you get lots of excess mucus, you get swelling, the airways get very irritable and hypersensitive, and therefore then the muscle tightens as well. So you can see the difference between the two sizes of the airways, and that's why you get the symptoms which I'll talk to you about in a moment. So it is a very common condition. Liv just reminded me that she heard that there was about over 30,000 people in Wiltshire who are currently registered, or maybe a couple of years ago in Wiltshire, with asthma. 5.4 million people in the UK, 1 in 12 adults and 1 in 11 children. Affects boys more than girls, but in adults it's more women than men, strangely enough. On average, 3 people die from an asthma attack in the UK every day. It used to be higher, it is coming down, but it's still significant. And I really wanted to state that just simply because it's a condition that needs to be taken seriously, not to scare people. Thank you. Next slide, please. So symptoms: coughing, cough, which can be productive with sputum, but it is sometimes a dry cough, particularly in children, and night cough is a big thing in children. Wheezing, so making squeaky noises, chest tightness, and shortness of breath. So all those things, or maybe 1 or 2 of them. So not everyone has all of those symptoms. Thank you. Next slide, please. So there are lots of different types of asthma. We don't really want to get too hung up on these. I'm going to signpost Asthma UK as a website to look on, and they go into much more detail than I'm going to. But there are lots of different kinds. Some people are very allergic, and therefore we might treat them slightly differently. Some people just have asthma symptoms in a certain season. So sometimes in the winter, if it's the cold air and the respiratory condition, sort of coughs and colds and so on, that make it worse. Equally, on the other side, it can be hay fever that would set them off. Childhood asthma, so you hear of lots of children, as I mentioned, having asthma, but equally adults can get it later in life. So with children, I say you won't necessarily grow out of it once. I don't use that term anymore with people. We used to say it, but actually in my experience, I've found that all those symptoms might diminish when children become teenagers or young adults. Often it can come back later in life, but equally, people who've never had asthma as a child can also then develop it later on, which always comes as a surprise to them. Exercise-induced asthma as well. So some people really only have symptoms when they're exercising. Occupational is something we don't really talk about very much, actually, but people say who've been bakers, who've worked with lots of flour dust or lots of other industries where they could have been exposed to very small particles, which can then affect their lungs and cause asthma. And then I've put at the bottom brittle or severe. We used to call it brittle. I think they call it severe much more now. Those are very rare conditions, but where it's more difficult to control, and those people would always be under hospital care, secondary care, because they can change very quickly. So they need to have perhaps a little different plan of action put in place. Thank you. Next slide, please. So how do we diagnose it? So the most important thing is a good consultation, really what we call taking a good history, really asking lots of in-depth questions about family history, about sometimes if people were born premature, they can be more likely because their lungs hadn't developed so well when they were little, or if parents smoked, so they were passive smoking through childhood, or indeed if their mother smoked when they were pregnant, there's more predisposition to getting asthma. Lots of other questions about allergies and what might trigger them, and so on, what symptoms they're having. We would also perhaps get them to do peak flow testing. So that's what that little picture is. I've also got one here. So that actually just looks at the forced blowout immediately. So it's a very quick test. We would look at variation on a day-to-day basis. As to whether because as I said, asthma is variable, so we would get them to do it morning and then evening and best of 3 readings and so on, and get a good idea of what's going on with that. Now I've put spirometry in there because these days the best quality is standard is to do spirometry, which is lung function tests in a surgery usually. Now at the moment during COVID, we've not been able to do that during the pandemic because of the danger of spreading the virus to other people, because it's a very forceful test. So we've had to sort of adapt how we do things, but normally speaking that would be gold standard to do lung function test and what we call a reversibility test. So we get them to do standard test and then give them some inhaler which opens up the airways, wait for about 15 minutes and then repeat the test again and see whether, as I say, there's some reversibility, so elasticity in the lungs and response. We also may get people to do exercise tests as well, which are very simple ones. At home. They may have blood tests because there are some blood tests that would show if there's an inflammatory response as well. There is also, I didn't actually write this down, there is also something called a FeNO test, which is a nitric acid test, which is something that is coming in much more and will be coming into general practice much more, where you can actually see a predictor much more for asthma by using this test, but it's not commonly used in general practice at the moment. But I think it will come. It's a case of working out how we do that. Also, allergy tests sometimes are useful, sometimes maybe useful further on down the line, but they can be used as well. Next slide, please. Thank you. So I've got lots of, this is a very busy slide. I had great fun trying to find pictures for all of this. So the sorts of things that might trigger asthma. So pollen would be one thing, and going down, exercise, as I said, can actually trigger it. Allergies to dogs, cats, horses, other animals, rabbits, feathers, and so on. Sometimes food allergies, obviously things like peanut allergies might be a little bit more specialized, but other food allergies can seem to set people off. The picture down the bottom is mold. So molds or funguses that might set you off as well, which can be in the atmosphere in autumn time, and the spores are in the air then. Sometimes cold can set people off. So one thing that we might advise is if people go out in the cold to put these days a mask on or a scarf over the nose and mouth to stop that sudden hit of cold, making their airways contract and respond. But equally, some people find heat difficult, or some people find just a change from one temperature to another can cause them to react. The middle picture is stress, so that can be quite a big, important trigger, which perhaps we don't talk about so much in some areas, but that can be key for some people. If they're stressed, then they may hyperventilate, and then that can cause their airways to tighten, and they can actually find themselves in difficulty. Smoking is a big one. It's an irritant, so that will actually inevitably mean that if someone smokes, it's much harder to control the asthma because they're constantly putting an irritant into their airways. But equally, bonfire smoke and so on can also cause a problem. The bottom figure is hormones. So in women in particular, changes in hormones can make a difference. So pregnancy can make a difference. Sometimes people improve and sometimes people get worse during pregnancy, or they find the difference when they've just given birth, when actually their hormones have changed again, or when they reach the menopause, they can find that things change for them as well. Aerosols, perfumes, anything like that can also set people off and actually make them react. The lady in the mask is really trying to show respiratory illness. So if you get a cold or a chest infection, that's going to often trigger the asthma, make the asthma worse. It's almost inevitable. Pollution as well. So that's been in the news quite a lot recently with a little girl who they're wondering whether, almost inevitably saying that her death was caused by pollution in London. So that's quite a topical thing with all the talk about environment at the moment. So certainly something to bear in mind. And then at the top, dust mites can cause a problem, and also airborne dust as well. Not all these things can be easily managed, but it's worth being aware of them. Some people may have other things that they find trigger their asthma. Next slide, please. So treatments. You've all probably seen inhalers, and we talk about inhalers a lot. But we in the UK we have several sets of guidelines, couple of sets of guidelines. NICE guidelines are slightly different to our British Thoracic Society guidelines. And so sometimes we would go with one and sometimes go with the other. Neither of them is right or wrong in so many ways, but some suit people better. But first of all, we would give 2 inhalers if we've diagnosed asthma. Because asthma is an inflammatory condition, we need to give an inhaled steroid. So we need to give a very minute amount of steroid, which deals with the inflammation in the airways and knocks that on the head. And usually it will work within 10 to 14 days and build up then. So I always say to people, don't expect a miracle straight away, but it should then start working. Alongside that, if you remember the picture at the beginning with the airways and the muscle clamping down, we give what everyone would have seen as a blue inhaler, which is a one that actually dilates the airways. So it's a short-acting bronchodilator, and it just works by relaxing the muscle and opening up the airways. And we call it a reliever, and the inhaled steroid a preventer, and often call it by the colours because it's much easier to identify, and people generally know what you're talking about. Blue inhaler is the reliever, brownish, they vary in terms of colour, would be the preventer. On top of that, we then would, if we find that the inhaled steroid isn't enough, then we may add in a long-acting dilator that works particularly well for exercise-induced asthma, or if people are getting a lot of night symptoms and so on, that might help. And we would combine it in with the inhaled steroid. And then there are licenses now to add a further bronchodilator in, which you can again combine. So there's 3 drugs in one, and that's the latest guidelines that have actually said that we can add that in as well. But we've probably not done that very often for asthma yet because it's a new addition. Although we've used it for COPD as well. There are also tablets that work along the allergic pathway. So if the inhaled steroid isn't enough and someone is a very allergic sort of person, then we may choose to go along the route of adding the tablet in instead of the long-acting dilator first. And that's where the different guidelines sort of slightly diverge, but they end up coming back together again in the end. Okay, next slide, please. So how to improve your asthma? The obvious one actually was to take your treatment, and obviously I don't want to step on anyone's toes, so if you've been given treatment from your GP or your practice nurse, then please adhere to that. And I think the biggest thing is actually we don't use the word compliance anymore, it's concordance, or actually making sure that people understand the importance of why they need to take their inhaler regularly. And it is something that they need to keep taking. If they take it and then stop, then the symptoms will come back, maybe not immediately, but they will come back. So really important that people do understand that and realise that's why we're saying it, not because we want to just give them medication. But on top of that, there are lots of other things that you can do to help yourself. So breathing exercises. So this is where Liv comes into her own, and this whole week of exercising for lung health and also singing for lung health. So in the Sing and Breathe, we talk about controlling your breathing, doing abdominal breathing, and that's really important. And there are some other breathing exercises that you may want to look up on Asthma UK. They do suggest a couple of other techniques as well, but all based around the similar sort of diaphragmatic breathing, so breathing right from deep down in your tummy. And that can really help when people are having an asthma attack or starting to, if they start panicking because it's a horrible feeling and then start breathing too fast, hyperventilating. If you can actually get them to calm their breathing down by doing these breathing exercises, that may stop them then going into a full blown, sorry for the pun, asthma attack. Exercise is another really important one because it will maintain or actually improve lung function. Now, obviously, you have to get to the point where the asthma is well enough controlled for people to be able to do exercise. But actually, once they can, it's vital that people keep exercising, and that's really key. And there are lots of well-known athletes who have asthma and control it really well. And manage to do that. I've shown a picture of swimming because actually swimming is particularly good because it's a warm, moist atmosphere, which your airways really like, rather than the cold and frosty one outside. Enjoying life and managing stress, those two kind of go together. The stress, as I said, is a big thing, and especially during the pandemic, it's been a big issue with people's mental health and isolation and so forth. And actually ways of managing stress by exercising, by talking to people, reach out and ask for help. But also the breathing exercises, listening to music, relaxation, all that sort of thing will help. But if some people may have issues that are unresolved conflicts in their life as well, which they may want to seek help for. So please do reach out. There are lots of helplines available, which you might find useful. And I'll talk at the end just about my role as a parish nurse as well. And I'm more than happy to talk to people as well, or signpost them in the right direction or appropriate direction. Another really important thing is having your flu jab. and obviously COVID vaccine as well, I would highly recommend. But the flu jab, obviously annually, is something that is really important, because if you get flu, then inevitably your asthma will be affected by it, and you can become severely unwell with it. So I would always recommend having a flu jab. Obviously, it's personal choice. People can choose not to. And then last but not by no means least, avoiding triggers. So all those triggers, some of them, as I said, are very difficult to avoid. It's not always easy to avoid dust, so in your house, but things like damp dusting, covers for your pillows and mattresses, mattress protectors, all those sorts of things are available. Asthma UK go into a lot of detail about that and will actually help give you advice, and there is a helpline as well that you can speak to people about. But being aware, for example, when the pollen count is high, Asthma UK and other websites will actually tell people when there's high pollution or high pollen at that time. So it's also worth being aware of that, and maybe, you know, even covering your nose and your mouth if you're going to be out when it's a high pollen count, to protect you from all the particles that, or the that might be in the air. We also used to say about dust mites that for children, you can put the cuddly toy in the freezer for a few hours, and that should kill them off. But there are lots of different ways of dealing with this. So it's trying to work through with people as to how to manage them. Next slide, please. So when I see someone, and I would say the majority of practice nurses who are trained in asthma, in fact, probably all of them, it's really good practice to give someone a management plan. We call it a self-management plan or a care plan, so that people know exactly what to do and when to recognise when symptoms are occurring and getting worse, so that you take early action. Do you remember I talked about the asthma deaths, and it was still a significant number? When they looked recently at the cause of the deaths, there were some, unfortunately, people who were very difficult to manage. But a lot of people were young people, perhaps, who hadn't been taking their treatment, but also people who didn't take early enough action. And that's really sad. So often those deaths could have been prevented. And so I would always stress the importance of understanding your management plan, knowing and understanding your body and knowing what's happening, recognizing what to do when. And the management plan is perhaps different for everyone, so I can't say, you know, what each person should do. It's something that you should have that discussion with your healthcare professional about. But easy examples: at the start of a cold, we would often say, take the reliever inhaler, the blue inhaler, 4 times a day while you've got the cold, and maybe for a couple of days after you're better. And that opens up the airways, maybe to prevent it settling on your chest. But also there are other ways of managing. So as I say, it depends what treatment you're on as to what you might do. So some people may be told to double up their inhaled steroid, others of, if they have combination inhalers, of increasing the dose for a short time, and so forth. But it is very individual. But really important, if you don't have a management plan and you don't really understand it, one, go back to your health professional and have annual checks, so that you actually do interact with your health professional and really know what to do. But also Asthma UK, this is an example. They have it clearly stated what to look for, the symptoms to look out for, what to do. But do seek help. That's what I say to people all the time. Know when to seek help. Please don't be afraid of asking for help. People are often afraid to bother health professionals, but actually we would much rather people sought help early on and had the appropriate treatment in order to prevent escalation of problems. Next slide, please. So these are my details, and obviously Liv will pass these on to you anyway. I'm in this role a parish nurse, and I'm employed by Grace Church in Salisbury at the moment for 1 day a week, and right now I'm sitting in the Bemerton Heath Community Centre. That's where I'm based at the moment. But I also see people, do some home visits when I can, and also phone calls, follow people up and offer them whole person support. So not just about respiratory, but about any condition, and isolation, and signposting people to appropriate help as well. The next slide, please. So just a very quick one. This is a map of the UK, showing where all the parish nursing services are in the UK. Sadly, none in Wales yet, but we're hoping to change that. There are about 88 nurses in the UK who are parish nurses, and about 75 services. So some parish nursing services have more than one nurse affiliated to it, and they work together. For example, up in Scotland, there's an amazing service up there who work with the homeless and do an amazing job. And I could tell you stories of all different nurses who do all manner of different things, depending on where they are. The lady down in Cornwall is very much centred on working with her elderly clients and been helping them, particularly through the pandemic. So it's very individual, and from my point of view, I'm open to see anyone. So you've got my details, but really to maybe help manage long-term conditions, be your advocate for your GP or other professional, refer on to other people. But on top of that, because I in this role I can offer spiritual help as well. So more than happy to discuss faith in all aspects as well. But certainly not there to push that down people's throats, but open to having a discussion. Thank you so much for listening.